Is it possible to have the presentation from the pen drive directly?
You have the pen drive?
Yeah, I have the pen drive.
हमारे कौन से हॉल में है?
वो सकते हैं
तो वो तो फर्स्ट फ्लोर पे है.
एजमेंट लगे खाना जो मतलब ना एजमेंट खाना
ऑडियो नहीं
ऑडियो नहीं है ना तो ठीक है. सर कौन सा वाला है? ये वाला.
अच्छा अब इधर से चालू करना पड़ेगा आपको.
Good morning, everybody. So nice to be in this Saturday morning with you all. Thanks for the invite to RSACPCON Organizing Committee. In the next 25 minutes, we'll look upon this very basic and essential topic, that is the perioperative blood transfusion and what is the current strategies and knowledge behind this perioperative transfusion. So blood, it's all in the last 10 or 20 years, the trend towards transfusion therapy is towards restrictive strategy for allogenic blood transfusion. So this is all because of this landmark study like TRICC, which predicted blood transfusion as an independent risk factor for all these complications which we don't want to come across in the patients. So in 2010, the WHO has approach this concept of patient blood management, which is primarily determines to have a early detection of perioperative anemia, which is one of the risk factors which suspects the patients to many blood transfusions. It tries to minimize the perioperative blood loss and also improves the tolerance in the postoperative setting for the anemia. So perioperative optimization starts with, so we have to correct the anemia before taking up cases, especially for when the patient is subjected to surgeries which have their own risk for high risk of bleeding. The various societies now come across from 2010, we can see the American Society of Anaesthesiologists as well as the European Society of Anaesthesiologists, and even the NICE guidelines approach towards this patient blood management. And I have jumbled all the recommendations what all these societies have given. So they now tell that to vigorously suspect coagulation and bleeding tendencies in the patient, even if the history is not there. So go for investigations which predicts the coagulation and the platelet dysfunction in the patients. And also try to correct the anemia by non-blood transfusion strategies to optimize prior to the surgery. And also any thrombotic events or the patients are in a situation to have anticoagulants or antiplatelets. So we have to combinedly decide with the surgeon whether to proceed with the antiplatelets perioperatively or to hold them without doing any further harm to the patient, as well as preventing the incidence of high hemorrhage inside the operating room. And also to have a blood ordering schedule for each institution. They insist to have a blood ordering schedule so that the efficient resource utilization is happening. And also they recommend the prophylactic antifibrinolytics like tranexamic acid to be considered in patients who are subjected for high risk surgeries for bleeding. So now the term is the blood conservation strategies, which are existing for a long time, but still they are getting importance recently. And the blood conservation strategies not only includes the well-known acute normal hemodilution or the autologous donation or the cell salvage. It all starts with even simple things like patient positioning or the intra-op hemodynamic monitoring or the strategies to blood pressure management, and also use of regional versus GA techniques. And if at all you use GA, what are the agents which are useful, like the total intravenous anesthesia have been shown to reduce the need for blood transfusion by minimizing the blood loss. And acute normalic hemodilution is gaining its importance back. So any patient who was to be losing blood more than a liter or normalic hemodilution can be adopted intraoperatively. And all the cell salvage also getting importance because earlier contraindications like malignancy and sepsis, they are putting leniency in this. Relative contraindications can also be included. So physiological adaptation, there is a difference between a normovolemic anemia and a patient who is hypovolemic anemia. So the adaptations in the case of hypovolemia, when there is ongoing hemorrhage, the physiological adaptations for the anemia is compromised. The most important adaptation what happens is in the cardiovascular system. The enhanced cardiac output and the low viscosity helps the cardiac output to increase to compensate, but unlike the normolic hemodilution, normovolemic anemia, so the hypovolemic is not able to compensate to its full stretch. So somewhere you can see there is a flat relation between the oxygen consumption and the delivery. Usually what is delivered to the tissues, it's 4 times is what's needed. So the delivery and the consumption can parallelly match to some extent at the expense of the extraction ratio. But at one point of time, the delivery, the oxygen consumption becomes delivery dependent. So that is the point where the blood transfusion should happen actually. It's difficult to find out this point or the DO to critical. So that is the transfusion trigger which are trying to find out. So hemoglobin is the most normal parameter which is used as a transfusion trigger. So can hemoglobin be the trigger is a big question, because unlike the normovolemic anemia, what is happening, the continuous hemorrhage is going to change the hemoglobin, and also the act of resuscitation, hemostatic resuscitation is going to make this hemoglobin a poor predictor or a transfusion trigger, because it's in the initial part of the hemorrhage, the hemoglobin is going to be high or normal or even high in spite of significant loss of red cell mass. So consequence of storage, so blood when it is stored, it is going to undergo a lot of biochemical and mechanic morphological changes. So this red blood cells is not going to have the same flexibility and elastic property as it passes to the pulmonary arteries, what discoid shape gives. It is going to lose such morphological changes are going to happen in the RBCs, which is going to make it more vulnerable and inefficient in oxygen delivery. And also the lysis, the continuous aging, the apoptotic changes happening in the stored red blood cells is going to release the free hemoglobin, which is going to be a scavenger for the nitric oxide, which is the vasodilator which determines the regional blood flow in the microcirculation. So all this scavenging is going to be very detrimental for the patient in such a situation of continuous hemorrhage. So as far as now the societies tell that the stored blood we not the age of the blood is not a big determinant in deciding the outcome of the patients. So the general tendency of the transfusion blood banks is to give whatever check comes in will be the aged blood is going to go out. That is what the societies are telling. So need not consider about the duration of storage of the red blood cells while resuscitation. So intraoperative blood loss, we have to assess. The basic step we have to see is the measurement of blood loss. We have done a lot of methods like the visual estimation, gravimetry or colorimetry. So all are good enough, but there is always a chance that we underestimate the blood loss. So assessment of blood loss, coming to the American Society of Surgeons classification of hemorrhage. So depending on the volume, we can see that all the physiological adaptation happens when the blood volume, the loss of blood volume is more than 20% of the patient's total blood volume. So that's when the system struggles to adapt. It uses all the adaptation maneuvers to supply the essential supply to the tissues. So maybe this is the blood volume that is that tells us that the transfusion is required. So any patients when they lose blood volume of more than 20%, they come to the point that they are at risk of getting an allogenic blood transfusion. So monitoring of tissue perfusion in what the societies they don't recommend very extraordinary monitoring during eye bleeding tendency surgeries. So look for the same parameters we are age old we are doing, like the hemoglobin, serum lactate based deficits, and also the use of monitors like dynamic parameters of volume status like the stroke volume variation and pressure variation, which are being used or also recommended for helping in finding the fluid responsiveness and the hemostatic resuscitation. Initial resuscitation, when the patient is losing up to the 10 to 20% of his blood volumes, the aim of the resuscitator should be to have a normal volumic normovolemia. To attain normovolemia is the trend, because it has been shown that the normovolemia is going to prevent the need for further transfusions. So all these things are true when the blood volume loss is less than 20%, but more than 20% the issue changes. So the crystalloid resuscitation is generally when the resuscitation is more than 1.5 to 2 liters, the outcomes start changing and it becomes bad for the patient. So restriction to up to 1.5 to 2 liters of the initial hemostatic resuscitation with crystalloids is advisable. An initiation of system with packed cells, so once the 20% of the blood volume is lost, they are at the risk. So that's when the allogenic blood transfusions comes into role. Most common definitions of massive hemorrhage. So when the patient starts massive hemorrhage, so we have a lot of definitions about massive hemorrhage. The hemorrhage which needs more than 10 packed cells for transfusion within a 24 hours this won't be suitable for our clinical situation, but any more than 4 packed cells within 1 hour, then it's called a massive transfusion. So these are the patients what we handle. So early trauma-induced coagulopathy, we know the trauma-induced coagulopathy, the entity is well defined now. So the trauma is initially is not only the coagulation defects, but also the hyperfibrinolytic changes that is going to be inducing the coagulopathy in the patient. So the lethal triad, namely the hypothermia, acidosis, and coagulopathy exists in the trauma patients. So surgery is also considered as a controlled trauma. Cross matching, so when in emergency situations, all these things we have to keep a knowledge on this. This cross match is going to take time, so it takes about 45 minutes to get the blood products arranged. So any emergency surgery, so well enough the blood bank should be informed, and there should be a transfusion protocol policies existing. So any blood groups, an uncrossed blood, when the blood group is known well enough, so it's uncrossed same type specific blood is good enough because it avoids around 98. Without a risk of ABO incompatibility, we can achieve a 99.8% of the safe transfusion. So other partially, if time permits, we can do a partial cross match. or it's a types antibody screen also, which takes around 15 minutes, that can also be achieved. So signs of coagulopathy, the society is what they insist. They all the age-old things of bleeding from the margins, wound margins, and any other pedicle hemorrhages from the other sites, non-surgical sites. So all these things will help us to diagnose the setting of coagulopathy in the patient. And if at all you have the lab parameters and the VHA viscoelastic assays, then also this is also useful. So causes of coagulopathy during massive hemorrhage. So mostly the initial resuscitation of the crystalloids is going to dilute the coagulation factors. Even though only 30% of the coagulation factors mostly is required, concentration is required for effective coagulation. But still the crystalloid dilution is going to give a dilution coagulation factors. And the other main hyperfibrinolysis also to be handled. So the use of tranexamic acid early in the resuscitation is what within an hour or within 3 hours is found to be useful, and when it is done more than 3 hours after during the resuscitation is not found to be good enough. It's bad in the outcome. And also citrate intoxication due to the more usage of more blood products, and also the platelet dilution, loss of platelet masses. So these are some of the causes of coagulopathy during massive hemorrhage, which we have to keep in mind while handling the transfusion. So management of massive bleeding, so early use of antifibrinolytics is insisted. So lower thresholds for cardiac preload and permissive hypotension, when this should be practiced. And introduce blood components early in the hemostatic resuscitation, and in the ratio-driven protocols, like they use packed cells, plasma and platelets in the ratio of 1:1:1 is found to be effective in bringing down the need for further blood products as well as the outcome of the patients. So once the ratio-driven protocol, once the surgeons or the combined the anesthetist knows that the bleeding tendency is decreasing clinically, then they can be changed into the goal-directed, like with the help of lab parameters like coagulation profiles and the viscoelastic assays. So some of the cutoff points is displayed here. So this is what the main drawbacks with the lab parameters compared to the viscoelastic assays is that the lab parameters, the coagulation profile is going to take time to get the readings. The VHAs are going to be time effective. They are going to be available at the point of care. So that is more important. So these are the cutoff points what they have insisted with the trauma guidelines. So coming to see the VHAs, they generally approach the coagulation as a global phenomenon. So they approach the role of coagulation factors, platelets. Also, this is based on the cell model of coagulation basically. So in the coagulation process, actually, it starts with initiation, amplification, and then propagation and stabilization. So VHAs look upon each of these steps. So TEG and ROTEM is one of the VHAs what is commonly used clinically. So typical, we have the tracings. We know that so both the ROTEM and the TEG are same. They determine the viscoelastic nature. So blood initially, when it is before clotting, is viscous, and then the progress of clotting, then it gives the elastic property to the blood. So this is the shear stress what happens when they starts clotting is what the aim of TEG and ROTEM. So this gives an idea about the clotting properties of the blood. So we have some of the parameters like R value, K value, alpha, and maximum amplitude. Also R value is mainly when there is a prolongation of R value is generally because of the defect of plasma, fresh frozen plasma, clotting factors. So we are supposed to give fresh frozen plasma, and the K and the alpha is more of a role of fibrinogen and platelets, and the maximum amplitude of the clot formation. So that gives the idea of about platelet function. So battery. So coming to the advantage of take over conventional clotting factors, so it gives a whole blood global profile about the coagulation status, and it's not entirely representative of the vivo hemostasis, because this is the blood, the hypothermia as a factor in determining the affecting the coagulation status is not evaluated by the TEG as well, like the coagulation profile, lab coagulation profiles. It can be one of the main advantages of TEG and ROTAM is that you can add agents which will help us to know the role of platelets and fibrinogen or the clotting factors in the process of coagulation. That is the added advantage what TEG and ROTAM gives. So limitation of TEG is same. It's real time. It needs the operator efficiency. So that is what the limitations of TEG. Adequacy of resuscitation during massive hemorrhage. The societies, they continue to stress the basic parameters what we monitor in the RSA standard monitoring. And the assets of transfusion assets, the stage has reached that the various assets of transfusion, both immunogenic as well as the non-immunogenic and infective, has reached a stage that it's not going to be much bothersome to think about this. The main complications is still the human error of ABO mismatch. So we can see the decline in risk of infective complications during allogenic blood transfusions have come down remarkably. So complications, we have all the complications listed. So periodic assessments for these complications during the process of hemostatic resuscitation should be adopted, like febrile reactions, hemoglobinuria, microvascular bleedings, and citrate intoxication all should be monitored during the process of handling the massive transfusion. So take-home points is preoperative preparation of anemia becomes more important. So this is one of the first step which is required to avoid allogenic transfusion. And prophylactic use of antifibrinolytics early in the phase of resuscitation have found to be helpful in improving the outcomes. And optimal hemostatic resuscitation with the introduction of blood products early in the process of handling the hemorrhage. And when the antifibrinolytics is not used as a prophylactic way, we can use as a expectant way early in the hemostatic resuscitation. And the ratio-driven protocols have changed the approach towards massive hemorrhage. And you should be aware of the complications of massive transfusion, and to diagnose then and there will be helpful to improve the outcome of the patients. In general, the basic aim of the patient blood management is to avoid unnecessary allogenic transfusion. Thank you.
Thank you, Dr. Venkatesh. If anybody has got any question, yeah. Professor Kundra, can we have a mic in the audience?
Thank you, Venkatesh. Indeed a good presentation. Now, when you have to give so many components, platelets, FFP, red blood cell concentrates, cryos, why can't we give whole blood? What's the issue of not giving whole blood and giving all the components of the blood one by one?
So that the current trend in transfusion therapy is also going back to whole blood. The main problem with the main problem with whole blood is the utilization of resources. That's what the blood banks, American blood banks, everything claims. And once you reserve a whole blood for a particular procedure, when your maximum blood ordering schedule of a particular institution is not good enough, then you are hampering the use of this blood for another 22, 40 hours for another patient. So it becomes a crisis management for the blood banks. So that is the main aim. But the tendency in transfusion therapy is going towards whole blood, which are shown to be